Welcome back to Torn. Recently, I created a video discussing the different graft choices that we use for ACL reconstruction, especially amongst the athletic population. Since then, I've been asked the question of, if I'm looking at someone's knee and their incision, how do I tell what graft was used? So in this video, we're going to break that down. I'm going to talk about how to look for what graft was used, where it's located, the specific incision that is made, and the importance of each incision as we move forward in the rehab process. So let's get into it. So the first graft that we'll look at, or the first incision, is the patellar tendon graft, or the BTB, or the bone patellar tendon bone. As you can see in the image, the incision, roughly 6 to 8 centimeters, is made from the inferior pole of the patella down to the tibial tuberosity. So it runs the length of the patellar tendon. Underneath this incision, the surgeon has harvested roughly the middle third of that patellar tendon, but also on each end of this graft, as we've discussed in other videos, we have a bony block or a bony plug that we take away from the patella or the inferior aspect of the kneecap, but as well as you come down the graft, we've taken a portion of the tibia where it attaches to the tibial tuberosity. So let's break this graft down. So it's a vertical incision made along the midline of the knee, or the anterior aspect of the knee, meaning the front of the knee. It extends from the inferior pole of the patella, or the kneecap, down to the tibial tuberosity on the tibia itself. We harvest the central third of the patellar tendon, and it includes those two bony blocks on each side. And lastly, the patellar tendon graft, due to the length of the incision, generally leaves the most visible scar that we can see amongst these autograft types. This graft is known for its bone-to-bone healing and strong fixation, one of the reasons why it's still considered the gold standard for ACL reconstruction. However, one of the cons of this, as we've discussed, is that it can induce anterior or front of the knee pain during the rehab phase or when someone goes to kneel. Next, we have the quadriceps tendon autograft. The primary incision for this graft is made above the kneecap, so the superior portion of the kneecap, or the patella, that's where the incision starts, and roughly 4 to 6 or 4 to 7 centimeters above that, based off what's needed for that particular athlete, that's the length of the incision. You will see a vertical incision made, but you can also see a horizontal incision made for this graft choice, depending on the surgeon. This incision allows the surgeon to take that bony portion of the superior portion of the patella. Similar to the patellar tendon, where we have those two bony plugs on each side, the quad tendon autograft has one bony plug. So the graft itself has a bony plug from the superior portion of the kneecap. The other side is not bony, so the other side is more tissue related from the quad tendon itself. So we have our main incision, a vertical incision, and centered above the kneecap. It starts at the superior portion of the patella, where we can see and use that bony plug from that side, and it extends vertically into the quadriceps tendon. The incision itself is roughly 4 to 6 centimeters, again based off the surgeon's preference, and again based off of what the athlete requires. So in addition to the incision that we make above the kneecap that we just discussed, you also see in that image an incision that is made just below the kneecap along the line of the tibia. This incision that we make here is actually used to insert the graft back into the knee itself. So we've just taken out the graft from the quad tendon. Now we need a place to insert it. So as opposed to the patellar tendon graft, where we make that incision along the length of the patellar tendon, we use that same incision line to reinsert that graft back into the knee. With the quad tendon autograft, we have to make the superior or the incision above the kneecap. Once that's taken out, you need a place to insert that graft back into the knee. And the incision that you see below the kneecap is where we insert that graft back into the knee along the native line of the ACL. So our secondary incision is just below the patella on the anterior tibia. It's used for graft passage and fixation. It's a slightly smaller incision than is placed above the kneecap, and over time is slightly less visible than the main harvest. This incision, the secondary incision, helps us align the graft through the tibial tunnel during the surgical intervention. So to recap with the quad tendon autograft, we have an incision that is placed above the kneecap, where we actually take the graft from the quadriceps tendon. Also, we have that incision below the kneecap, where that is placed to actually insert the graft into the knee along the line of the ACL. Lastly, we have the hamstring tendon autograft. The primary incision for this graft choice is made on the medial or inner side of the knee, along the line of the tibia where the hamstring tendon and the gracilis muscle attach to the tibia. The location of these two tendons attaching is called the pes anserine. Generally, this incision is very small, roughly 2 to 4 centimeters, and it is generally vertical. Sometimes it can be slightly curvilinear or oblique, just based off the surgeon's preference. Once this incision is made, the hamstring tendon, including the semitendinosus and the gracilis tendon, are carefully dissected and harvested for graft preparation. Because of its medial side location, this incision can be less noticeable when viewing the knee from straight on. So for the hamstring tendon autograft, we have a medial incision near the pes anserine where the semitendinosus and gracilis attach to the tibia, roughly a 2 to 4 centimeter or oblique or curved incision, and generally it is less visible compared to the quad tendon and patellar tendon autografts. So why does this matter? Well, for athletes or patients, it's important even prior to surgery to have an understanding of where these incisions might be made and where they will be over time, but also from the standpoint if you're understanding like the cosmetics or the aesthetics of where these incisions are, that may play a role into the graft choice as well. From a medical professional standpoint, if an athlete walks into my clinic, even if I look at that knee, I have a pretty good understanding of what they've gone through just from looking at their incision themselves. So it's important from both sides, not only the patient, but also the medical professional, to have a good understanding of where these incisions are and have a good understanding of why they're there and why they use them. That way we can make the rehab process and going forward slightly easier. If you'd like to learn more about different types of ACL graft choices, click that link above where I discuss in depth the pros and cons of each graft choice that we can use for athletes or patients and what works best for you. As always, drop any comments or questions that you have down at the bottom. Don't forget to like, subscribe, hit that notification button for more daily ACL related topics.